Hello, my name is Kevin Hall. I'm going to talk about my experience of involving patients and the public in the design of my clinical research and the impact that that had on my academic interest, my clinical practice and the design of the study interventions. I hope this will be of interest to anyone involved in patient and public involvement, anyone involved in applying for national funding streams like NIHR awards, and anyone involved in the design of clinical research. So my experience of involving patients and the public began when I was in the application process for my clinical doctoral research fellowship. I approached the Sussex RDS and they were very helpful in helping me put together a meeting with patients who were currently on the surgical waiting list. So I wanted to get their specific perspectives on the design of my study. So we sat around in one of the boardrooms at the hospital and discussed various aspects of the study. Lots of interesting points came from that discussion, but I'm going to discuss one of them today and go into some detail. So all of the patients who attended that meeting, they'd all attended physiotherapy at some point, and the majority of them had attended physiotherapy for their shoulder pain. Now obviously the physiotherapy was unsuccessful because they were currently on the surgical waiting list. But what I wanted to know was their experience of physiotherapy, and in particular what they felt were the potentially beneficial effects of physiotherapy. So not how physiotherapy helped them specifically, but what were the mechanisms by which physiotherapy can promote recovery in people with shoulder pain. So I posed the question, and what came back was not potential benefits, in fact not a single potential benefit was listed by any of the patients, but they did come back with some concerns about whether physiotherapy would have the capacity to in fact make their condition worse or increase the structural pathology. So these are a couple of the quotes. How do you know that you're not doing more damage or causing more injury? What about the tears, the tendon tears? Might these get bigger? How does physiotherapy deal with tendon tears? So I was slightly alarmed, thinking that I was in the process of designing an exercise rehabilitation program for these patients to help them recover from their shoulder condition, thinking that they're probably not going to do these exercises if they feel they're going to make them worse. So then I went away and did a little bit of reading about health-related behaviour change, started looking at the health belief model, which has been used widely in the past. So the health belief model states basically that if we're going to make a health-related behaviour change, so in this case performing physiotherapy exercises, which take something like 10 or 11 minutes a day, that's a new behaviour that I need to engage in. So whether or not I do that seems to be related to my perceived susceptibility of getting a condition, and whether it is a serious condition or not. So in this case it's known, they've got the condition, and it's pretty serious because they're on the surgical waiting list. So that aspect we know. So then whether or not they engage in this new behaviour is going to be related to the perceived benefits versus the perceived barriers. So it's a kind of a simple seesaw effect. If the barriers outweigh the benefits, then they're not going to engage in the new exercise program. So then I was thinking about these quotes again, and the concern about structural pathology certainly seemed to present a significant barrier, and the lack of perceived benefits that they were able to list meant that the seesaw was definitely swinging in the wrong direction. So then I went away and did some more reading, engaged the patient and public group to discuss sort of educational processes, potential barriers to physiotherapy, and came up with I suppose an educational syllabus where we have 3 barriers to exercise adherence and some evidence-based beneficial effects of engaging in exercise rehabilitation. So I'm not going to go through all of those now, but I'm going to kind of give you an example of one of them. So one of them is a process called mechanotransduction. So these cells are fibroblasts. Now what fibroblasts do is they sit in our tissues and they're mechanically sensitive and they're involved in a process of repair and regeneration. So for example, in the tendon cells of the shoulder, they would be called tenocytes. So if you take these cells and you mechanically stimulate them, there are little receptors in their membrane that, when they become stimulated, initiate a sort of a cascade of signalling events within the cell that ultimately leads to gene transcription and the production of amino acids. Those amino acids are the building blocks of the extracellular matrix. So they are I suppose, the complex proteins that will repair and regenerate tissue. So in order to reframe that for patients, these are the cells, these tenocytes, these are the cells that sit in your shoulder. And when you jiggle them around, you poke and you push and you stress and you strain them, they will kickstart your body's repair mechanism, and they will replenish and regenerate the injured tissue in your shoulder, making it stronger. If that tissue is stronger, it will be able to tolerate the forces of life more effectively without generating pain. So that's one of the examples in which education might be able to provide patients with some potentially perceived benefits. So, I suppose one of the things that my belief system has changed a bit. I'm now fairly convinced that education is the doorway to rehabilitation. We can have lots of fancy exercises, and there are lots of clever research trials that have helped design some good quality exercises that we know are pretty helpful in terms of rehabilitating painful shoulders. But if we can't open the doorway to rehabilitation through an educational process, then patients might be unable to access those exercises and their beneficial effects. So if we talk about the impact of patient and public involvement, which is what today's about, if we talk about the impact of that meeting in one of the rooms at Western Sussex Hospitals 2.5 years ago, and the impact that had on my clinical practice. So it's definitely changed the design of the study interventions. The educational syllabus that I've designed is completely different to what I was initially thinking, based on that patient and public involvement meeting group. It's had an impact on, therefore, the educational processes that I've delivered as a result of the training and the trial. So the physiotherapists that will be delivering the interventions need to be trained up. So they've been through an educational process, teaching them how to educate patients and how to deliver the syllabus. So hopefully that will have an effect on their clinical practice over the next 30 or 40 years. It's had an impact on my academic interest and maybe what comes next in terms of my research interests. It's had an impact on my clinical practice. So I definitely integrate a much stronger educational component to my patient contacts, which last week I was seeing 40 to 50 patients a week. So over the next 30 years, that's going to be 63,000 patient interactions that are going to have a stronger educational input as a result of my patient and public involvement meeting. So hopefully that gives a little bit of insight into the impact of involving patients and the public in the design of my clinical research, and how that's changed my research, my clinical practice, and my research interests.